Good morning, good afternoon, good evening, wherever you are joining our webinar today. I am Stephen Grubbs, the Vice President of Clinical Affairs at the American Society of Clinical Oncology, and I want to welcome you to our weekly ASCO Global webinar series entitled Cancer Care Experiences and Lessons During the COVID-19 Pandemic. Today we have two fabulous topics. One is strategies for managing surgical oncology patients in Japan during this pandemic, and the other is the impact of the pandemic on research. I want to remind everybody that the presentations and answers to questions about COVID-19 presented on this webinar are provided by the American Society of Clinical Oncology for voluntary informational use by providers. This information is not intended to substitute for independent professional judgment of the treating provider in the context of treating an individual patient or developing practice policies and procedures. Next slide, please. Next slide, please. I'm happy to have Mr. Doug Pyle join me today in hosting this event. Doug is the Vice President of ASCO's International Affairs. I'm very pleased to introduce Dr. Abdulrahman Jazieh, who will be our moderator today. He is the Chairman of the Department of Oncology at the King Abdulaziz Medical City in Riyadh, Saudi Arabia. Welcome, Dr. Jazieh. Please proceed. Next slide. Yeah.
Yeah, this is Dr. Jazieh. I would like to welcome you to our ASCO weekly webinar regarding COVID-19 pandemic and cancer care. It's my privilege to have two distinguished speakers that are highly accomplished talking about two important topics. We will start with the first presentation with Prof. Kazuhiro Yoshida, who is the director of Gifu University Hospital, professor and chairman of Department of Surgical Oncology at Gifu University in Japan, and he will be talking about strategies for managing surgical oncology patients in Japan during COVID-19 pandemic. Prof. Yoshida.
Okay. Thank you very much for your kind introduction, and it is my great pleasure and honor to be able to talk this morning about the strategies for managing of surgical patients in Japan during the COVID-19, and especially its impact on providing surgical care to oncology patients in Japan. Next slide, please. So topics today is clinical and epidemiological features of COVID-19 in Japan and general strategy for infection control against COVID-19 and how the COVID-19 affects the treatment of cancer patients and the delivery of surgical oncology service and action to minimize the risk to surgical oncology and the take-home message lastly. Next slide, please. So let me start with the background briefly. The COVID-19 is a tremendous threat to healthcare system because no specific symptoms, rapid pneumonia progression occurs, strong infectivity, more than 10% of the patients are asymptomatic. 5 days before symptoms occurs, and 20% of patients progress to severe pneumonia, and infection are easily occur while eating face together. The risk factor of severe progression is not yet known. Cancer, COPD, heart disease, hypertension, diabetes, smoking are regarded as some of them, and no treatment yet established. Asymptomatic patients into the hospital and hospital infection, even with the sufficient caution, easily collapse the medical care system. Next slide, please. Let me show you the number of increase of Japanese patient. I'm sorry about the busy slide, but if you look at the center of the slide, the first patient were found at the beginning of January, and charter flight back from Wuhan. And all of you remember very well about the Diamond Princess at the beginning of February. And most of the people in Europe and US did not imagine about the rapid overshoot at March. And Japanese patients increased at the end of March to April. And if you look at the left side of the slide, Gifu is located in the center of Japan, and Gifu University is an intermediate side national university, about 1,500 outpatient clinic a day and 2,500 cancer patients treated in a year. So the number of COVID is very low compared to Tokyo. And what is more important is that the number of deaths in Japan is very low, about 1/10 compared to US and Europe. So next slide, please. The reason is not yet known. So general strategies for infection control against COVID is demonstrated, and patients were classified into 3 categories to prevent the overflow, the infected patients, and collapse the medical system. Basically, PCR positive patients were sent to the hospital. So only severe patients requiring ICU treatment and ventilator are sent to the advanced medical care hospital. Mild and moderate are not sent to that hospital, but admitted to regular hospitals or recently commercial hotels with the medical care, including nurses and doctors. So next slide, please. So COVID-19 affects the medical and surgical oncology because in patients with active COVID-19, interruption of anti-cancer treatment should be strongly considered. Firstly, continue anti-cancer treatment if it is for urgent control against cancer. And secondly, defer systematic anti-cancer treatment until the patient has at least 1 negative PCR test for COVID-19. And surgical care can increase the risk of post-operative complication and progression of COVID-19. Next slide, please. So let me remind you, how does the COVID-19 affect the delivery of surgical oncology? Tracheal intubation, extubation, and mask ventilation, and bronchoscope, chest drainage placement, electric scalpel treatment such as digestive organs, laparoscopic surgery can generate aerosol in the operating theater that ruins the function of the whole hospital. Importantly, this situation can occur even a patient without any symptoms. Next slide, please. So surgery in areas that are likely to be exposed to body fluids such as saliva, urine, feces, vomit, vaginal discharge has a high risk of infection. Head and neck cancer patient has higher risk for COVID-19. In gastrointestinal, urological, gynecological cancer patient, surgery to be deferred in a patient with asymptomatic or minimally symptomatic cases, including benign disease or even malignant polyps, such cases are to be deferred. Surgery to be considered in cases of emergency, including intestinal perforation due to cancer, and significantly symptomatic cases like pain or bowel obstruction or bleeding is required during blood transfusion. Next slide, please. So I'm sorry with the complicated slide, but it's simple. This is a surgical decision-making process to triage surgery patient according to the Japan Surgical Society. It is 3-point. The patients to be considered, firstly, institutional resources, including ventilator or available or operating capacity are available or not. And secondly, status of the COVID-19 infection, whether it's positive or negative, and also the disease level, according to the life-threatening or not, from level A, B, C. So in general hospitals in Tokyo and also in my university, the number of operating patients are restricted to 70 to 80%. However, cancer patients are usually operated, except head and neck tumors and dental surgery and neurosurgery through the nasopharyngeal approach. Next slide, please. So what is needed as an action to minimize the risk to surgical oncologists and staff? It's an asymptomatic COVID-19 infected patient should be excluded to prevent the coronavirus contamination in the operating theater. So importantly, screening for all preoperative patients are mandatory, of course in a hospital also. In addition to the patient flow lines in a hospital from entrance to exit is one way. And the medical staff uses a different way from the patient. And all of the patient and staff's surgical masks are on. And more importantly, multiple preoperative medical interviews for patient and families are important. Symptoms including fever, history of contact with infected person, behavior history before hospitalization, and they are performed at the time of hospitalization and before surgery. And very importantly, screening of PCR on all the cases and chest CT examination before operation when general anesthesia is required. Very importantly, we have to bear in mind that about 6% of the screened patients from Keio University are positive without any symptom. So this screening is very important. However, there are some limitations in the strategies because it requires a lot of manpower and some cases that cannot be diagnosed even after screening. And we don't know how reliable is the accuracy of PCR, and it cannot easily increase the number of screening PCR. And the cost is from hospital. This screening PCR is not covered by national insurance by the government. So the Union of National University is asking Prime Minister to cover this by the national insurance now. The next slide, please. So what changes in post-operative care for oncology service is minimize blood tests, scans, prescriptions, and routine tests to diminish risk of viral exposure. Prefer changing to oral anti-cancer drugs and shorten the duration of adjuvant chemo. For patients with recurrent neutropenia, consider dose reduction of anti-cancer drugs over using GCSF to reduce the risk of febrile neutropenia and hospitalization. And also make full use of online medical consultation and prescription using telephone and videos. Next slide, please. So I would like to conclude with the take-home message. the COVID-19 can cause an explosion of patients and collapse of the medical care system. To prevent the rising mortality in Japan, patients were stratified according to the severity of the symptoms and admission to the appropriate hospital. Anti-cancer medical and surgical care can lead to progression of COVID-19 infection. Surgery should be restricted in case of COVID-19 infection, except life-threatening. Screening of patients by PCR, CT, and medical interview is absolutely necessary for delivery of surgical care to oncology patients. Consider using oral anti-cancer drugs and shorten the duration of adjuvant chemo, and online medical visit can help the risk reduction of in-hospital infection. Next slide. Thank you very much for all your kind attention. Thank you.
Well, thank you, Prof. Yoshida, for this nice comprehensive review. Now, for our participant, the way we are going to do it, we will hear from our second speaker, Prof. David Kerr, who is a professor of oncology at Oxford University. We'll have a couple of minutes of comments about the topic we just heard about. Then we'll open it for question and answer. So I would encourage all those who are watching us now to post any question they have so we can ask them to our, pass them to our speakers. So, Prof. Kerr, do you want to comment on surgery in cancer patients?
I should say arigato, Yoshida-san, for that superb presentation. It was incredibly clear. And of course, it doesn't surprise us that within a well-organized, highly structured medical care system that we know operates in Japan, that you've organized yourselves so quickly. So I think three elements seemed important to me. One is a prospective study for the future. The incredibly low death rate that you have is something that needs to be explored in terms of its genetic basis, in terms of how different healthcare systems respond to the virus. But there must be some very important learning lessons that we can make from that. I thought your Japanese Society of Surgical, your Japanese Society of Surgery, moving very quickly to have that set of very clear guidelines. Again, it doesn't surprise us in the way that we know that surgical oncology is very well organized. And for the society to come together so quickly and to issue such clear instructions again shows how coherently our Japanese colleagues work together. And interestingly, your guidelines are very similar to our own Royal College of Surgeons in London. So that sort of sense that the international communities are sharing and working together, it seems very important. Certainly, similarly in the UK, we are delaying a number of our cancer surgeries too. It fascinates me that maybe 20 years ago, I did the first national audit of cancer waiting times in the United Kingdom. Patients with a proven diagnosis of cancer, breast, lung, bowel, were waiting sometimes months for treatment. With some work that we managed to do then, we showed that there was a window of opportunity of around 3 months. Beyond that, we were losing patients through metastasis and lack of control. So I think, without wanting to sound too cold, epidemiologically, when we look back in this crisis, we should be able to monitor and map the impact of the pandemic on our practice and whether that has caused a catastrophic change, which we hope is temporary in cancer survival, or whether it's a blip, will be very interesting for us again to work internationally and transnationally to look and to understand. But it was a fantastic talk. It was very clear. And again, lessons that we can take from Japan and apply within our own healthcare systems. So thanks very much again.
Thank you very much. Nice comments. And firstly, the treatment result of Japan is it looks good compared to other countries. We don't know genetics or not, but treatment of ECMO or Avigan, such kind of things might affect the prognosis of the COVID-19 patient. We don't know yet.
Okay, thank you, Prof. Kerr. Just to ask a couple of questions to Prof. Yoshida. So, um, do you have a dedicated operating room for patients infected with COVID-19? Do you have like set-up room just for COVID-19 patients, and how do you handle these rooms?
Unfortunately, not at the moment. If the patient number is increased, we have to organize that. But generally, the operation rooms are positive pressure. So once the COVID patient is in the positive pressure operating room, it's spread very quickly. So intubation and extubation should be in a different room than the COVID room.
Oh, okay. So because so one of our surgeon asked this question about the negative pressure room. So it has to be the intubation of patient for surgery has to be in negative pressure room, correct?
Exactly, correct.
Because that's something has to do with wound healing if you did that generally. Generally, you don't do it in negative pressure room, correct?
Exactly.
Yes. Okay. What about the staffing then? I know probably because you don't have that much caseload, but from your experience or from what you heard about surgical literature, do you recommend that also the staff who are handling the COVID-19 positive patient should be also separate, like a clustering the staff? Those
Yeah.
who manage.
Yeah, ideally, it should be a different team. Concentrate on COVID patient, and others are COVID negative patients to protect the usual usual operations. So it's ideal.
So before I continue, I want to encourage our participants to post any question, please, to our professors on the chat box, on the question answer box. Okay, the next question, Prof. Yoshida. So, if a patient tested positive for COVID-19, what will be, and it's elective now, it's not, I take it life-threatening situation, you are going to operate anyway, but in an elective surgery, what would be the requirement to feel safe to take the patient into the OR and do surgery? Infected patient?
Yes, infected patient, we have to wait, whether it is emergency or not. In case of waiting patient, we have to check with the PCR negative at least twice, and also screening the CT whether the pneumonia is positive or not. This is essential things.
Okay, so you need two negative pressure, two negative tests, and CT scan doesn't show any pneumonia. Okay.
Exactly, correct.
So and I take it that you do the PCR test on all surgical cases, pre-surgery, on all of them. It's like requirement, correct?
Yes, in our university it's mandatory, but not so many hospitals in Japan cannot routinely test the PCR or CT because the national insurance does not cover the routine test for PCR before operation. So we are asking Prime Minister or Minister of Health to include the PCR screening before surgery as to cover national insurance.
But for those who have access to it, you recommend it to do it before any surgery, correct?
Any surgery requiring general anesthesia.
Okay, so let's take the scenario of somebody who's having respiratory symptoms, flu. So still people in this pandemic, still they have a regular flu. What do you do? Do you have to quarantine them for 14 days, do PCR testing on them and wait till the result is negative, or what would, because many times, it could be negative in the beginning. I don't know. So we all have some doubts about the sensitivity of the test and so on. Somebody having upper respiratory infection symptoms, what do you do with them? How do you handle them?
Yes, it's a very difficult situation. At least we have to have the history of contacting whether the infection positive patients or not, and then screen with the PCR and CT scan before operation. Even if the PCR is negative, sometimes the virus is not positive in the nasopharyngeal portion, but in the periphery of the lung. So we have to be very careful about that.
Okay, so good, thank you. The type of surgery you select. Now, we read something in the literature that even laparoscopic surgery may have increased risk of complication and infection and so on. Would you default to laparoscopic surgery if you can, to minimize exposure to the aerosolization and so on?
Yes,
would the selection of the procedure, be important here?
Yes, extubation of laparoscopic port is sometimes very difficult because the positive pressure comes from the abdomen. So, however, we prefer laparoscopic surgery to minimize the operation. So we have to be very careful to check CT and PCR before surgery to confirm that it is negative.
Did the use of personal protecting equipment change during this pandemic? Are we wearing more N95 in the OR? If there is anything that we are doing differently now in terms of the protective equipment that we wear in the OR, in the operating room?
Actually, the PCR and CT negative cases we do not do, but for emergency operation, we protect ourselves and staffs are protecting by PPE and face masks in case of extubation and intubation. So as far as the CT scanning and PCR screening, if it's negative, we do the same way.
Okay, that's great. That's good. Thank you very much. Do you have any other comments to say, Prof. Yoshida, before we move to the next talk? Any other comments related to the surgery? Any points you want to highlight?
No, thank you very much.
It was a pleasure. Thank you very much. It was great hearing from you. We are looking forward to hearing from you comments about Prof. Kerr talk. So David, now we'll come to you, and we'll like to hear, very much there is a great interest about the impact of COVID-19 pandemic on research. So if you'd like to share with us your experience, we're looking forward to hearing from you.
No, thanks, Abdulrahman. Great to be able to speak to everybody today. And let me bring warm words of welcome from the Dreaming Spires of Oxford. If we could have the next slide, please, David. I think it is important for us to talk about the research aspects because that's what binds our community together in some ways. Before going to talk about that in a bit more detail, I just wanted to give one small piece of evidence from our own coronavirus register. We set up a register to monitor the epidemiology of the disease in cancer patients a couple of weeks ago. We have about 1,000 patients on board. It's a large collaborative effort, as you can see here. And just to highlight one particular data point, next slide, please. And one of the things which troubles us is the impact of chemotherapy on outcomes. And without going into the huge details, this is we now have over 1,000 patients, and what we've demonstrated is that patients whom we try to match in terms of age, disease stage, gender, of course, being important, it doesn't look as if patients who've received chemotherapy within the 4 weeks prior to a definitive diagnosis of COVID-19 has any negative impact in outcome. And one of the knee-jerk reactions that our healthcare system had was that we must stop all cancer treatment because we have immune-depressed patients. The virus will run like wildfire through, and therefore the knee-jerk rather than logical response was saying, let's stop all chemotherapy now. So here's just a small data point suggesting that, at least in our hands, 1,000 patients, a small sample, recent chemotherapy does not seem to be hugely negatively impactful. Next slide, please. So when it comes to research, I think the focus will be, for all of us listening today, predominantly on clinical research and what the immediate impact of the pandemic is. But I think also for us to think what the longer term prospects may be, because I'm sure that all of us recognize the way that we deliver cancer care now, as Prof. Yoshida has demonstrated, as I know you've discussed in ASCO webinars before, is that we're going to change how we deliver cancer care. I deliver my busy Friday clinic from the kitchen table using video conferencing tools such as this. So we speak to 30, 40 patients every day. We do it using video conferencing, and the patients love it because it saves a long, complex journey to hospital to see me for 15 minutes and taking a day out of their lives. So there's a prospect of look at how this will change how we continue to deliver cancer research. One of the main impacts, of course, the immediate one, is how we refocus clinical activity. Certainly in the National Health Service, we were told to clear the decks for a tsunami of COVID-19 patients and therefore to suspend as much inappropriate clinical activity as possible. So large movements of clinicians, lack of clinical staff to conduct clinical trial activities, inability to get access to the facilities that we would require, diagnostic tools and imaging. I last worked in an intensive care unit in 1983 as a very young doctor in Glasgow, but I've been trained to look after ventilated patients. This isn't a good sign for the ventilated patients, but it shows the extent of the anxiety that our health service had. In order to cope, even old docs over the hill, finished docs like me, were being retrained to be intensivists. Next slide, please. So we need to think about how the host organization responds, how the sponsor responds, and how we as a clinical scientific community respond. The single theme that runs through all of this, whether it's us as individual clinicians, whether it's the sponsoring entity, pharma, biotech, academic trials group, whether it's the regulatory authorities, the safety of the participant is of primary concern, and therefore everything that we do in this new world must be about maintaining patient safety. And therefore, the first thing that we did through our clinical trials office in Oxford was to look at the risk-benefit ratio of continuing a trial, both in terms of those participants who had already been registered and the recruitment of new participants. And for the host, response could be to halt recruitment, but to continue to look after those patients who already had been recruited, continue with a different approach to delivery, which we'll discuss later, or I think the sort of nuclear option, to stop or suspend the trial completely. So these are the different ways that one could respond, I guess. Next slide, please. I think that's it. Thank you. So in terms of the sponsor, again, we're looking at ethical, medical, and moral sets of responsibilities. Of course, the sponsor needs to understand that access to staff, facilities, trial participants is going to be hugely negatively impacted upon. As I say, we are running all our clinics from the kitchen table. I'm on call as a sort of third line reserve for ventilation, and I'm on call for our local hospital for acute oncology emergencies, and for the hospice because they've lost 5 of their consultants who are off self-isolating because of mild COVID disease just now. So this is a huge difference to our working practice. Sponsors must realize that. The routine follow-up monitoring activities that are part and parcel of every trial that we do, clinical examination, collection of routine blood tests, access to imaging facilities is going to be hugely disrupted because of productizing, as we heard from Prof. Yoshida, how we move COVID positive and COVID negative patients through the system. The data collection should be minimized to essential information only. This is a big thing that we've got. When I was a youngster, when I first came to Oxford, we set up the Quasar Trials Group. Quasar means quick and simple and reliable. And for those of you who know Sir Richard Peto, his focus has been in very large trials. This is statistical reliability. And the quick and simple is we should focus only in collecting endpoints which are really important. All of us who have been involved in clinical trials, all of us, me included, want to overcomplicate the protocol. Wouldn't it be nice to have a biopsy? Wouldn't it be nice to do some extra blood test to look at subsets of monocyte activation during a cytokine storm, and on and on and on? But this should be a time of refocusing on what is absolutely essential to saying, can we meet the trial endpoints? Can we modify them? Can we keep it quick and simple and reliable? I think the idea about using electronic patient records is a really interesting one, and we'll come back to that later because of its impact on patient confidentiality. And of course, we need to provide support for protocol deviations because these do need to be reported to the regulatory authorities. Next slide, please. So aren't we blessed that one of the, some politicians say never let a good crisis go to waste. And for the past 5 years across our National Health Service is a rather monolithic organization. It has 1.3 million employees. It's the fourth largest institution in the world after Chinese People's Republic Army, Indian Railways, Walmart, NHS. It's a big, clumsy organization. For 5 years, we've been trying, as a university employee, we've been trying to get remote access to patient data from our university computers. With the pandemic, it took us 5 days. So there is something about how the social distancing, the working from home, has compelled and has driven forward rapidly a remarkable change in how we work and how we access data from home. Now, should we give that same responsibility to trial monitors from clinical research organizations and so on? Our regulatory authorities are happy to do that, but so I can sit and I can look at the patient electronic records at home. My wife's a professor with me, Rachel. We share a clinic together. We sit at the kitchen table together, and our children are too small and daft to have the faintest idea what's going on. But you can imagine, though, if you're sitting at home, I would like to make sure that the CRA, the trial monitor, was in a private area, that their relatives wouldn't be able to look over their shoulder at confidential and personal data. And therefore, we're having a debate just now about making sure that trial participants can consent to any identifiers leaving the site electronically and to be assured that their confidentiality will be protected. So it works for us as a clinical group, but sharing that externally to CROs, to CRAs, is something that we think we probably need to get explicit consent from patients for. Next slide, please. Changes to monitoring visits. Of course, let's use phone calls, let's use video conferences. And again, we've had approval from our regulatory authorities in Europe that this is completely kosher and acceptable for at least as long as the outbreak renders in-person visits impossible. And I'm sure this is one of the changes which will continue. If we can do this efficiently and safely above all things, then there's no way that we're going to go back to face-to-face monitoring and visits unless we absolutely have to. We do need to manage risks. If we've got patients who are on a novel drug regimen with the potential side effects that all of us are used to managing, looking after our cancer patients. So again, we need to make sure that safety is of paramount importance, but regular interrogate. We're using a telephone app. We're asking our patients to download a telephone app that allows them to record on a daily basis what their side effects and so on are. And those data are fed back to our nurse practitioners so that we have an automatic warning system if patients are recording side effects that we think might require intervention. Another innovation that has been brought forward by the pandemic. And as we said before, all along, if we feel that patients are running into problem across the trial, we really do need to rehearse the benefit-risk balance and consider suspension if we think there's a definite trend of increasing side effects that we're not managing sufficiently well. And remember, part of this, our patients are frightened to come into hospital just now. So patients may be staying at home with significant symptomatic side effects, but they're hiding these because they don't want to access a hospital system because they're terrified of COVID. That's why we thought we would use the patient app as a means of trying to get around this. Next slide, please. Don't let a crisis go to waste. So I'm absolutely sure that remote video telesite monitoring is here to stay. And quick, simple, reliable. I like large trials with simple, clear endpoints, which will change practice, and cluttering trials up with 1,000 blood samples, 1,000 skin biopsies, pulling hair to measure for the phosphoproteome, all the weird stuff that I've done, in the past. We need to be very careful how we apply that. My laboratory is looking to repurpose anti-cancer drugs for COVID. We're working with an inhibitor of macrophage stimulating factor 1 that might be involved in reducing monocytes' ability to cause a cytokine storm. We're looking at epigenetic inhibitors, which might stimulate the body's immune defense mechanism. Is that a good thing or a bad thing against COVID? So there's a lot of work going on in our cancer community, seeing can we apply our biology and science and understanding to this disease. I think we'll see in retrospect what happens. I think the point that Prof. Yoshida made, that we'll be able to look back, particularly in this year, and see what the impact has been of delaying surgery, of perhaps delaying chemotherapy, of switching to oral chemotherapy, of reducing intensity and so on. I've seen some recent modelling recently, I don't think I agree with it, suggesting that in the NHS that the COVID pandemic may lead to as many as 16,000 unexpected cancer deaths this year in the United Kingdom. Now, when I was a young kid, I spent a lot of time looking at the mathematics of pharmacokinetics, pharmacodynamic modelling. So I'm sort of moderately, mathematically attuned. But these modelers, they always get it wrong. But we're going to have to look back in retrospect and see what the impact has been. And I think the other impact will be incredibly how the COVID-19 is fast-tracking drugs through with an extraordinary rapidity. As I say, we're repurposing some cancer drugs, and they're in a queue to get into a national trials platform for randomized phase 2 trials in COVID-19. In 5 weeks in the United Kingdom, we've entered 5,000 patients into 100 patient randomized phase 2 trials of a variety of novel, different antiviral agents. Utterly extraordinary. And if we can mobilize that degree of research infrastructure so quickly, I think it allows us to be able to continue to press to make that available potentially for our cancer patients. Next slide, please. And this should be the last slide. So again, this is Professor Yoshida and I are both Oxford types. Prof. Yoshida spent some of his training time here, so it's delightful for him to be sort of getting back to his hometown, as it were. Francis Bacon, who was an able politician and legislator, unfortunately went to Cambridge. I should explain that Cambridge University is a spin-out from Oxford. So for those of you who just need to understand who the senior university is, he said, "Namitipsa scientia potestas est." He said that knowledge is power. Now, Politicians weaponize knowledge. They keep it to themselves. They erect transnational barriers. But what we do through research, our community of coming together, is to share knowledge. And that's truly how knowledge becomes power. With that, I'll finish. Thanks very much for listening.
Thank you, Prof. Kerr, for this interesting presentation and sharing the experience with us. Now, while we are waiting for our participant to post any question, I would give the microphone to Prof. Yoshida to make comments, please. Prof. Yoshida.
Yeah, thank you very much, David. Your pictures reminded me of my very good old days which I spent in Oxford. And thank you very much for the very excellent talk and instructive talk and distinguishing the clinical trials and usual clinical. In Japan is also the situation looks like a same. For clinical trials, no enrollment and enrollment retarded, and protocol deviation can occur because patients stay in homes and cannot visit. And as the first peak of COVID, even if it calmed down, the second peak will occur in the winter, maybe. So for a while, we have to survive or coexist with the coronavirus for a while. So in this situation, I would like to ask you two things. One thing is the online visit. It's very fascinating, but sometimes it's difficult to identify the side effect or adverse effect. And also, is it possible for the patient, even if he cannot visit the hospital, but can visit the clinic nearby and examine the blood test or CT scan? Is it available in the clinical test or not?
So two very important questions. We agree. I mean, all of us who are gathered today are used to delivering our outpatient care with face-to-face visits, the capacity to examine patients, to lay hands on patients. Has been this the way that we've been trained and so on. So I do miss that element of it, and it cannot be replaced with a video conference. What we find, though, is that when we have our face-to-face conversations with patients, when we ask them about the side effects they've had with their last cycle of chemotherapy, they tend to minimize them, they tend to play them down, they tend to forget about them. So with this app thing that we've got, because we ask the patients to record twice daily a whole set of questions relevant to the chemotherapy, we find that gives a much clearer pattern of the duration and extent of toxicity than asking the patient to remember back. So these tools are not replacing face-to-face, but they can be a very useful adjunct for making it happen. In terms of blood tests, absolutely right. We post our blood forms to the patients and they go to the local GP surgery to have the bloods done. Patients are much more confident of travelling a short distance to their primary care centre to have a blood done than coming to the hospital. Psychologically, our patients associate a trip to the hospital as a trip towards a place which is full of the virus, in which the virus has been concentrated. And of course, there's some truth in that. So we localize as much as possible. Our scanning systems all tend to be centralized within hospitals. We're having a discussion just now about how we can take complex scanning centers out into the community. But we haven't done that yet. It's a plan for the future, and I think it would make a difference to earlier detection of disease in the United Kingdom. Our patients tend to come with delayed diagnoses, but it's a plan in action, not one that's been delivered yet.
Mm-hmm. David, can I ask one more question?
Yeah, please, go ahead. Go ahead.
Yes, concerning the data monitoring. Remote data monitoring, such as source data verification by sponsors or a PI, can be conducted recently. In the era of COVID, is it possible, or is it possible or prevalent?
We, I guess this is the access to the electronic health record. So in our National Health Service, all patients have an electronic patient health record, and it's about should we allow the CROs or intermediates access to this, at least during this period of time. And our regulatory authority in the UK has has said yes to that. We should allow it. We should ask the patient's permission to get consent. And we need to make sure that those who are receiving the information, if we have a CRA for a drug company working at home filling forms in, we need to make sure they're doing this in isolation of the rest of their family. Because what we wouldn't want is, you and I having a conversation like this, and the next door neighbor or the children or the dog or the cat being able to view and understand personal and private information. So with those caveats, it's something that we're doing. We're exploring it just now. Patients have been very happy to consent to this, at least in our experience. But we'll see how this experiment works. But so far, so good.
Great. Thank you.
Thank you. So, okay, passing some of the question to Prof. Kerr. So, you have mentioned, David, some of the things that is going to stay, like the electronic visits and so on. What are the things that you think is going to stick in the future of research in terms whether changes now taking place or it may take place in the near future because we did not have enough time to implement it? So what will be the major shift in the way we are doing research that you will see?
Yeah, no, I mean, in terms of clinical research, you've said it yourself, Abdulrahman, that I think the remote video conferencing, using more electronic, digital data capture, personal data from patients, so making them perhaps more intimately involved in data collection themselves, particularly in terms of side effects, patient-reported outcome measures, and so on. I think that's here to stay. I think patients, tele or video conferencing as a catch-up, depending on what stage of the trial, works very well. Of course, it depends whether we're doing phase 1, phase 2, or phase 3. We understand that with phase 1 trials, we do have to generate more data, more complex data sets around blood samples, biopsies, and so on. So I don't see us reducing the complexity of those. But I do make the plea again, particularly for phase 3 trials. I would rather that we had large, simple, reliable phase 3 trials than trials which were a little short of power but had very complicated protocols. When I look at some of the big pharma protocols, they cram too much in terms of data collection that often gets in the way of us getting a proper endpoint that would be practice changing, that would make a real difference to how we go forward. I think in terms of looking at laboratory research, I think that's going to be difficult. I think we as cancer researchers have been in a very privileged position for many decades of having strong charitable support, strong support from government. And one of our dominant areas of supporters for clinical and laboratory research is Cancer Research UK. I think, if not one of the biggest cancer research charities in the world, they've projected that their income will drop by 50%. Yeah. That means that good science will not be funded. That means that current science will be stopped. That means that scientists will be put out of jobs. And I think government also, it wouldn't surprise me if NIH, if our Medical Research Council, if the Japanese government don't start to switch funding from conventional areas like cancer and so on to pandemic preparation, immunology, antiviral treatments and so on, because these have been relatively neglected areas. There are some great scientists working in the area, but not at scale. And therefore, I think we might see some strategic changes in funding that may, I was going to say, penalize cancer researchers, but we've had it very good for a long time. So I think that'd be one of the longer term implications too.
Yeah, you covered the area because about the impact of economical situation on the research. So that was an important question in mind. And also you covered the issue about the impact on the regular cancer research. What about, let's reflect a little bit on the rapid publications, or at least leakage of some of the information even before proper peer-reviewed process. What do you think about that, in terms of the, rigorous of doing things, the impact of what's going on now in clinical practice and so on?
So I will shock you by giving a sort of rather flexible answer. So I used to edit Annals of Oncology. I'm editor-in-chief of the Oxford Textbook of Oncology with Doug, who's online. We set up the Journal of Global Oncology for ASCO. So I'm in deep, in terms of running journals and editing them. But remember that peer review is there to guide. Peer review is there to guide the editorial decision. It's not to make the editorial decision, and therefore, with some of the senior editors that we have in some of the great journals, the leading journals, I have trust that these people will be able to make appropriate decisions about the quality of the papers that are coming in very large numbers in those areas. So I'm not as fussed about peer review in the world-leading journals, the ASCO journals, the ESMO journals, the Lancets, and so on. They have very strong editorial teams and boards that can make decisions without having to go out for peer review. That may sound absolutely shocking, because you think that I would be defending peer review to the death and going to the barricades to do all that. I mean, peer review is helpful, but it is not the end all or be all of what, as editors and chief of journals, how we make decisions and so on. In saying that, and because I don't understand it, there's an amazing amount of really dreadful information out there. Oldsters like me grumble on and on about social media and how bad news spreads like wildfire, how crazy theories are promulgated, sometimes from the very top, I'm sorry to say, as well as from the bottom up. So there's a lot of background noise, a lot of it very conflicting, a lot of crazy people out there stirring up just mad pot ideas and so on. But in terms of the stuff that comes through to the New England, to the Lancet, I think it's okay. I think peer review is useful, but it's not a gold standard necessary. Does that shock you? Are you disappointed in me?
No, not a bit. You always surprise me anyway. So, so David, 1 minute. What is the silver lining of COVID-19 for research? 1 minute, so we can tell it, Doug.
Okay. No. For me, it's a telemedicine thing. I think it's suddenly the embrace of digital health, I think, will reduce trial costs. It will increase recruitment times. It will make it much easier to move forward. I think we've made trials too complex, too paper-based, and there's a folie à deux between the regulators and industry, who just ask for more and more and more and more. Industry, we as academics never push back. We don't fight the FDA. We don't fight the EMA. And it's a sort of folie à deux. Both sides are mad, complexity. And it's now too time-consuming, too expensive to do trials. COVID will teach us that we can do them quick and simply and reliably. Quasar, there we are, Quasar. That's the model for the day.
Right. Yes, go back in circle. Thank you very much, David. Thank you very much, Prof. Yoshida. We enjoyed having you, and we learned a lot. Thank you very much. I will turn now the microphone to Doug. Doug, thank you.
And that's two fantastic talks. Thank you to my old friends, Professor Yoshida and Professor Kerr. Fantastic discussion, very well moderated by my old friend, Professor Jazieh. So thank you for your insightful comments and really excellent talks. We've learned so much from you. I'd also thank all of you who are joining us today from around the world. We are a global community, and we all need to learn from each other, and thank you for joining us today. We hope that these webinars have made a difficult time just a little bit easier. I would like to encourage all of you to please join us for our next webinar next week, May 12th, at the same time. We have an excellent, another excellent slate of speakers. incoming ASCO President, Dr. Lori Pierce, Dr. Jazieh from Gustave Roussy, and Dr. Stephen Chan from Hong Kong. As always, recordings will be made available on the ASCO coronavirus webpage, as well as other resources. In addition, if any of you would like to have a certificate of attendance, please send an email to us. The email address is there, international@asco.org. And again, thank you to our speakers, to our moderator, and to all of you for joining us. And please take care and stay safe. Thank you.